Extremely good morning, everyone. And we are yet live for another session. Today, we are talking about global trends in myopia epidemic, prevention, control, and future strategies. To talk about this topic, we have Professor Dr. Quresh Mastaki. He is joining us for a very important topic. It's a need of an hour. He's a renowned corneal and anterior segment surgeon in advanced training in Rochester and Boston, USA. He has received honorary FICS and a prestigious honorary FAICO award from All India Ophthalmology Society as for his lifetime contribution. He has been honored for 24 peer-reviewed significant publications, contribution chapters to more than a dozen ophthalmology books, and has conducted the National Ophthalmic Quiz for the last 25 years for international conferences. He is also the consultant ophthalmologist at Maskati Eye Clinic at Mumbai. Sir, over to you.
Thank you, Saurabh. And as you correctly said, can I share my screen?
Absolutely.
Thank you. So, Saurabh, you were referring to this myopia. It's now more of an epidemic. So, let's review the global trends in myopia as an epidemic. Can we do something to prevent this epidemic from looming further? Can we control myopia? And what should be our future strategies? Will be what I will try and cover in this span of time that I have. And I thank you for giving me this opportunity to share my views with the rest of the audience. So you can see how it was looming even before the internet became so widespread. Almost 1/3 of people in USA, adults, we are talking about, and this is data which is 12 years to 15 years old. The situation is only worse now. 1/3 of people, adults in USA and in India are myopes, and in the Far East, where there is Taiwan, South Korea, China, Singapore, where because of genetics and because of their tiny Chinese and Japanese script, and for various other reasons, the incidence is more than 2/3, 3/4, sometimes as much as plus 90%. So why does myopia progress? Myopia is short-sightedness. How does it progress? For various reasons. Chief of them is environment or the lifestyle. Right from the beginning, toddlers are given cell phones and they're hunched down on that. Small children in India and many countries, it serves as a surrogate parent. Both parents working, the person, the helper at home, puts the TV or the mobile on while they're having their food to get them to eat and things like that. Unfortunately, when we were students, we had a lot of outdoor activities. But nowadays, even homework is given on laptops, and the assignments are given to be done on the laptop. They're asked to research on the internet. And so the use of the PC, laptop, tablets, iPads is booming. The number of hours of closed work is increasing. All these things contribute. The number of hours of outdoor activity is going down. They are less exposed to natural light, which can control myopia, and more exposed to indoor lighting. They have bad posture while they are sitting because no one has told them about posture and how to sit. The more you bend your neck downwards to see your mobile phone, the more you get a crick in the neck as you grow older, and the more chances of your myopia increasing. How close should the reading material be to this to your eyes? And a very neglected factor is food habits. healthy food rather than junk food does contribute to slowing down myopia progress. And of course, certain things which as of now we still can't do much about, and that is the genetic factors which are there. But the chief thing that we must understand is that in myopia, when you put a spectacle glass in front, we put biconcave glasses in front of the eye because the eyeball is too long. So normally in myopia, the rays of light focus very much away from the retina. When you put biconcave spectacles in front of them, the rays of light focus on the retina, but the peripheral rays of light focus behind the retina, the red line that you can see. So that is called a hyperopic defocus. That means those peripheral rays are not focused on the retina. You need all the rays to be inside the eye. What is called myopic defocus is desirable, but spectacles give you hyperopic defocus in the periphery. So the brain feels that I need to expand the eye more to catch the rays of light in the periphery, the red area. So the eyeball expands more and therefore the myopia increases. For every 1 millimeter excessive increase in the length of the eyeball, you get a -3 diopter increase in the spectacle. So the chief problem is the hyperopic defocus and the increase in axial length. So this is just another picture to show you that this is the spectacle lens which is there, which is biconcave. And this biconcave lens gives you beautiful focus at the macula, the central portion. So the child sees the blackboard very clearly. But in the periphery, the rays of light are focusing behind the retina, as you can see here and here, which is hyperopic defocus. Even if this child was blind, this hyperopic defocus would still cause the eyeball to elongate. So, therefore, we know that spectacles, which is the mainstay, 90% of patients with myopia or short sightedness the world over are given regular single focus spectacles. So, they do well to help them to see better, but they are acting at counter purposes to and not preventing the eyeball from increasing in length and therefore not controlling myopia. For controlling, you need, like in the bottom slide, all the rays of light to focus within the coats of the eye instead of going outside in the periphery. So in the old days, people didn't really understand, but they gave lesser number. If your number was -5, they gave you -4, thinking that if you're undercorrected, most of the rays will still focus in the eye. But the problem occurs, yes, if you undercorrect, most of the rays focus within the eye, but the vision, central vision is blurred. When the vision is blurred, that also acts as a stimulus to make the eyeball axial length increase. So it was counterproductive. So why are we talking about myopia today for such a length of time? Because it's not an individual's problem. It's a public health problem. The increase in prevalence of myopia, if your myopia is more than -5, it is considered high myopia, leads to greater number of myopia related complications like retinal detachments, posterior staphyloma, CNVMs, and amblyopia or lazy eye, and even cataract and glaucoma, which is a public health problem because the state or the insurance companies have to spend a lot of money to rectify, say, a retinal detachment, which would not have occurred if your myopia had been controlled in your childhood. So, myopia definitely is a condition with social, educational, and huge economic consequences. That's why we need to address it very squarely now. So, in reality, an uncorrected refractive error leads to learning difficulties. If the patient is not given any glasses, then he can't see the blackboard well, he can't perform well in school. He is an introvert because he is underperforming as far as his classmates, and that leads to the inferiority complex. So we need sensitivity and skill in detecting and evaluating these children who remain withdrawn and show less interest in socializing and interactions. So it's a socio-economic problem. I told you that there are many what is called comorbidities if there is high myopia, which is defined as greater than -5, you can get myopic macular degeneration, detachments, myopic retinopathy, glaucoma, cataract, and so on. We'll see all of them one by one. So first of all, maculopathy. You see the picture below. This is the red thing that you see is a bleeding spot or a hemorrhage at the macula. Macula is the center of the retina, and because the retina is stretched, unfortunately, God makes one single, the inner lining of the eye is called the retina, and God makes it in one size. So if the eyeball is longer, that retina has to be stretched. When it's stretched, some blood vessels can break, giving rise to this maculopathy and degeneration at the macula. So if your number is between -7 and -9, you have almost 125 times more likely to develop myopic maculopathy, which affects your vision sometime in life. What about retinal detachment? So the retina can detach because it is stretched. You see in the top picture, the retina in the upper layer here is no longer attached to the back of the eye. That's called a retinal detachment. It hangs like a curtain. Here you can see it hanging like a curtain over the optic nerve or the optic disc. This is a retinal detachment. And if you're myopia of -15 and above, you're almost 100 times more likely to get a detachment than somebody who's not a myope. Then there is cataract, posterior subcapsular cataract, means a cataract at the back of the lens. Again, above -6, about 5.5 times more likely to develop this. So, how do you reduce the prevalence of myopia? Based on the data from several Asian countries, overemphasis on academic performance and paucity of structured outdoor activity. We must encourage children to spend more time outdoors and less time on academic work, especially that involving gadgets. So that might help. And the powers that we should think of myopia prevention strategies and reassess our current educational systems. Let's go through these in specifics. So we know that greater time spent in near work affects myopia. A pioneering study by Rose et al. Way back 15 years ago said that for a 6-year-old, you should have ideally less than 1.5 hours a day on near work. Less than 1.5. Moderate is 1.5 to 2.5, and high is 2.5 hours per day. So no child should spend more than 2 hours or so in near work in a day, which includes school work and extra and after school work. Again, same Rose et al. In 2008 said the greater amount of outdoor activities, and these are peer-reviewed journal articles, the greater amount of outdoor activities halts the onset of myopia. So it prevents myopia from coming in if you can get the children to spend more time outdoors. And what is the ideal amount? Ideally, they should spend more than 2.5 hours outdoors in sunlight. It is not the same as spending time in a skating rink indoors. So low outdoor time is considered as less than 1.5 hours. So ideally 2 hours or more should be spent outdoors in outdoor activities. Because when there is close work environment, near work, hyperopic defocus becomes more. There are several theories of how sunlight helps. Perhaps there is higher amount of dopamine released. Perhaps the spectral distribution of natural light has something to do with it, because artificial light doesn't help. What do we know more also? That the younger the myope on first detection, the more the chances of progress. So we have to be more aggressive with therapies besides spectacles. If you detect a child, say at 6 years of age or 7 years of age, as you can see in the first bar, if the child is detected at 7 years of age, the chances are, if you just give him spectacles, that every year his myopia will progress by almost one. While a child who first develops myopia due to genetic problems at age of 16, as you can see in the last bar, the chances of it progressing is it would progress only by about 0.1 diopters a year. So from 1 diopter to 0.1. So the younger the onset, the idea of this slide is to tell you that the younger you catch a child with myopia, the more aggressive you have to be in insisting on more outdoor work, less indoor work, and some of the other treatments that I will show you. So we came out with myself and my optometrist Chandrasekhar came out with a risk point system, just like we have risk factors for hypertension, which is like stress and other things. We have a risk point system where we put points on this. If the child is only wearing single vision glasses, we give him a -1. And if the child has one parent who's got myopia, we give him 1 point. If both parents are myopic, we give 2 points. If there is 2 generations of myopia, we add a point, and so on. If there's poor eating habits, we add a point. If the child is doing homework in poor light, we add a point, and so on. So then we came out with that. We came out with a risk point system that if you have 3 points total out of these risk factors, so you have less risk factors, there is low risk of progress. 6 points or more is medium risk, and if you're more than 9 points, you are at a very high risk of developing irreversible changes like retinal detachment, myopic maculopathy, cataract, glaucoma. So we need to be very aggressive to prevent all these changes in adulthood. So we need to put in myopia control measures. So, Brian Holden et al. In Australia came out with a beautiful picture, this slide that you can see, that if there are two myopes, and we use myopia control measures, which I will talk on the next few slides, if we manage it well, he will progress to minus 3.5, sorry. And if we don't manage, if we just give simple glasses or even contact lenses, you will progress to almost -7. So we can half the progress by doing what is called myopia control measures. And this is free of charge. This slide is available free of charge if you just go on the net to see what are the risk factors. So what are the modalities that we have to control myopia? And I'll talk about some of these. We have something called orthokeratology, which is the use of special contact lenses to be worn at night. We have from China, over the last 5 or 10 years, something called red light therapy, by which we give child some exercises during the day. We have multifocal contact lenses, which is going out of favor now. We have topical low-dose atropine drops, and we have special defocus spectacles. I'll talk about each of these a little more in detail. So first they said, okay, look, if hyperopic defocus is there, let's have spectacles which have got the central area corrected for distance so the child can see well. And in the periphery, let's give plus numbers so that the child can focus. There is no hyperopic defocus. So they put what is called a double D, that is you see in the top picture. Center is myopic -3, -4, whatever it is. And the upper they put hyperopic glasses, plus numbers. But it was not so effective because when the child looked up or down, he saw everything very blurred. Then we came out with Myokido glasses. These are patented. This is my grandchild who was wearing them early. So they had a hole in the center. There's no number in the center. So she had -1 spectacles. She could read without glasses. So we had a hole in the center where only when she was reading at home, she read through that, so that was 0. And the periphery at plus 4.5. So there was a hyperopic defocus was corrected every time she did reading. Of course, she could not use these spectacles outdoors because you need that -1, and not in school. So these were Myokido glasses with central hole and a plus 4.5 all around in the periphery. So if she used it only for reading, she was very comfortable. But it had limitations. You couldn't use it in school, you couldn't use it for sports or outdoor activities. So then we came out with special myopia control spectacles, which has got a combination of myopic control in the center and a hyperopic defocus at areas which the child is not using. They need customization. Depending on refraction of the child, may take about a couple of weeks to deliver. It's relatively expensive. In India, it costs the equivalent of about 15,000 Indian rupees. Advantage is that the patient can wear it continuously in school, at play, everywhere, for distance and near. And astigmatism also can be corrected with this. And many multinationals have entered this. I have no commercial interest in any of these. But the chief ones which control more than 90% of the market between them are from Zeiss, Essilor, and Hoya. So let's talk about, there are three different technologies. We won't go into the details because there's a lot of physics involved. The first one is called HALT technology. HALT stands for highly aspheric lenslets technology. So the center has got the myopic control, as you can see, and you get these small lenslets, tiny islands which are there. There are about 100 islands, so arranged in 8 to 12 concentric rings in the spectacle. When the child wears the specs, you can hardly make out these, and they are clinically shown to slow myopia progression significantly. So highly aspheric lenslets technology, or HALT. This is from SLR Stellest. Then there is something called DIMS technology, which is from Hoya. The brand name is MyoSmart. They use the DIMS stands for defocus incorporated multiple segments. Again, I'm not going to bore you with the details, but basically the central vision zone for everybody has to be there, where the myopia -3, -4 is corrected. And there is a honeycomb pattern in the spectacle outside, which has got which causes a myopic defocus or counteracts the hyperopic defocus to prevent the eye from elongating. So this is DIMS technology from Hoya. And Zeiss has got MyoCare. And this is, they use CARE technology. Cylindrical, CARE stands for cylindrical annular refractive elements. So again, the central area is always clear, and it's got these concentric multiple rings over here, which prevents the hyperopic defocus. Sorry. So what do all these lenses do? As I told you earlier, if there is one slide you need to remember, is that traditional lenses cause this light focusing in the periphery behind the retina, called hyperopic defocus, while the central area is well focused. So this is the traditional biconcave spectacles. While with the myopia control, either the HALT or the DIMS or the CARE technology, somehow they focus with up to about 4.5 diopters plus in the periphery, maybe -4 in the center. Astigmatism also corrected. So all the rays of light focus within the retina, so that there is no hyperopic defocus, no stimulus for elongation. So the first technology that I told you was special spectacles. Another thing which was discovered quite by accident was orthokeratology. Now, orthokeratology has been around since about 30 years. What is orthokeratology? It is wearing of contact lenses with what is called reverse geometry. Again, I won't bore you with the physics, but typically these lenses were worn at night. So the parents put the lens on for the child, 6-year-old, 7-year-old child with -6, -7 number. These contact lenses worn just before going to sleep, and the child goes to sleep with the lenses on. So we've been taught always never sleep with your lenses, remove your lenses while sleeping. This is the technology turned inverse on its head. Why? Because this is reverse geometry. Just like in contact lenses, the contact lens is shaped like a mountain, like a dome, which fits over the dome of the cornea. In orthokeratology, it is shaped like this. So it presses on the cornea. The central portion is flatter. It presses on the cornea. So when it presses on the cornea, it reduces the axial length. And that remains for about 8 to 10 hours, sometimes 12 hours during waking hours. So in the morning, the parent removes the contact lens and the child can go to school and see well. So the computer calculates how much of reshaping should be there depending on the number. So ortho-K was used for children who didn't want to wear glasses or who could not wear glasses. They had some problems with the ears where the frames didn't fit, or they had some Down syndrome or something like that. So these were used for them, and we found by accident that when they wore these ortho-K lenses, their myopia did not progress. So temporarily, we thought there was only temporary slowing axial eye length elongation, But now we find that the effect is quite permanent in about 45 to 50% of cases. So now orthokeratology is used in a big way. Again, orthokeratology lenses are expensive. I am speaking from India, where they are not made in India. We have to import them. But for those who can afford this and those whose parents can do this daily at night, putting it in and removing it in the morning, this is a good way. Almost 50-60% of children will have myopia progress controlled with ortho-K uh, lenses. So we talked about special spectacles, we talked about ortho-K lenses. Let's talk about atropine, which is drops. So it's a very easy thing to do. You just have to put one drop at night in both the eyes for children. This again came out with people experimenting with the commercial available, which was 1% and 2% atropine. And they found when they put this in the eye, the progression dropped by 50%. But it produced a lot of side effects. So the first study was way back 20 years ago, which was called the ATOM-1 study. ATOM stood for atropine in the treatment of myopia. And it was a double-blind randomized study, placebo-controlled, with 400 children over a 2-year period. Of course, they used very high strength, 1% atropine. We are now using 1/100th of that strength, 0.01%. But for this study, they used it for 2 years, 24 months, and they found that there was reduction in the progress of myopia by 77% compared with the untreated eyes. So you can imagine, see the result, 1.2 diopters was the progress of myopia in 2 years in the control group where there was no atropine, compared to just a quarter diopter progress. So if the child had -3, it went to -3.25. As compared to if a child had -3 and did not use atropine, it went to 4. So, but you could not use 1% because of the side effects, the blurred vision, the loss of accommodation. So then they tried several other percentages. They found the higher the percentage, the more efficacious it was, but the side effects were more, so there was high dropout rate. So then they finally arrived at 0.05% or 0.1%. They tried this and they used 20 children as a control group, and the study went on for almost 5 years. And again, they found that the increase was just 0.3% versus 0.86% in the control. So lower strength also works. And then after ATOM-1, there was ATOM-2, the atropine for the treatment of myopia study 2. And this was very conclusive. They used very low concentration of 0.01%. And they found that side effects were hardly any. And in 2 years, the mean progression was just 0.3 diopters as opposed, and about 0.5 diopters in the 0.01%. So they said half a diopter over 2 years is acceptable, and let's go for 0.01% as compared to the higher strengths. So this is the 5-year ATOM-2 study results, and we found that children who presented with myopia progression of more than 0.5 were then restarted on 0.01% atropine therapy after a washout period. And they found that there was lowest rebound effect with 0.01%. So for all these multiple reasons, 0.01% is the standard now chosen. One drop at night for it can be continued up to the age of 16 to even 18 years. So let's go to the meta-analysis, and several studies put together. They found that the effects are much better in Asian eyes than in Caucasian children. So the American FDA was very slow in giving approval because they didn't find that great a result. But Huang et al. In 2016, with 30 clinical trials, meta-analysis of over 5,000 eyes, they found that 1%, 0.5% was slightly better as compared to 0.01%, but 0.01% was efficacious and had the least side effects. So which are the children who should be offered this treatment? All children over 5 years of age with a documented increase of at least half diopter of myopia in the past year, and after thorough discussion with the parents. See, always make sure that the parents are with you. If the parents are lazy or the parents go out at night for partying, they are not going to put the drops. There's no point in starting this treatment. And exclude children with anisometropia. Anisometropia is the difference in the number in the two eyes, or a high astigmatism, or children with syndromes like Down syndrome, mental retardations, children with myopia due to causes other than genetic, like retinopathy of prematurity children, or after you've done a cataract surgery. So those myopes are not going to improve with atropine. So we do a baseline axial length study and keratometry before we start the treatment. So to summarize about atropine, 0.01% atropine is fairly safe for children above 5 years of age, can use 0.05%. So if I find that I'm using 0.01%, but it's not controlling it the way I want, and the child cannot afford the special spectacles, I will try with 0.05%. Again, the side effects are very minimal, and it does tend to work in cases where 0.01% doesn't work. Luckily, 0.05% is also available in our country, India. So it should be continued for at least 1 to 2 years. Don't give it up. Many parents come to you after 3 months or 6 months. It's too early to assess. So continue for at least 1 to 2 years before you say that it's not working. If it's not working, move to 0.05% for another year and then check. And if it's still not working and the myopia is progressing, then you can stop the atropine. And if suppose at the age of 15 or 16, the number has not progressed for the last 1 or 2 years, then you can give a washout period, stop the atropine for a year and see if there is again progress, you can continue, restart the atropine. Otherwise, you can keep it off. How long should you continue? I have been continuing it even up to 18 years of age, though the studies all stopped at the age of 16, but there is no harm in continuing up to the age of 18 as well. After that, most myopes stop progressing. Let's move on to another therapy. So we talked about special spectacles. We talked about ortho K contact lenses. We talked about atropine, where we said 0.01% is ideal. This is an exciting study which comes mainly from China, which is RLRL, or repeated low level red light treatment for myopia. So this is a machine. You can see this young girl looking into this machine. She is looking at a pattern which is seen inside. At the same time, red light of a particular wavelength is going into her eye and stimulating her retina and her choroid and preventing it from increasing the axial length. We'll go into details in the next few slides. So we know that prevention and treatment. So what did the Chinese do? They knew from Rose's study that spending extra time outdoors somehow helps. They said, forget outdoors. Let's have glass walls and ceilings for schools. Does it work? No. Then they said, suppose we increase the lux. So instead of say 10 lux of light in the room, lux is a unit of light measurement. You have 100 lux of artificial light, halogen lights or LED lights. Does it work? It doesn't work. And we can't all afford to have open air schools on beaches and things like that outdoors. So they said, if we can't put children in natural light, let us assume that it's the red light of a particular wavelength which is stimulating the eye to prevent it from increasing in size. So can we use part of sunlight, the red light only, and see whether that works? So Jiang et al. Proposed that if you use red light at a wavelength of 650 nanometers, they didn't just arrive at it by chance. They had been experimenting with various red lights for treating amblyopia or lazy eye. And that seemed to be working. They said, let's see if it works for lazy eye, whether it will work for myopia. So they took red light at a wavelength of 650 nanometers in a beautiful multicentric trial. They found that it was effective, safe, and highly acceptable to users. So what was the inclusion criteria? It was a single masked parallel group study. Myopic children with moderate myopia, aged 8 to 13 years, so not too young, not too old. Spherical equivalent refraction or SER between -1 to -5, so moderate myopia, not high myopes. Not much of anisometropia. The difference between the two eyes less than 1.5. So if one eye had 3, the other eye had less than 4.5. And astigmatism or cylinder of less than 2.5. So not very cylindrical numbers. Children were assigned to single vision spectacles, as I told you about. Also, I've shortened it to SVS, single vision spectacles, or the only single vision spectacles, or single vision spectacles with red light. Now we know that single vision spectacles don't halt the progress of myopia. So that served as a control group. This red light therapy was given at home. So the machine was given at home. It's a simple machine. As you can see in the picture, it's a desktop device. It delivers the light at an illuminance of roughly 1600 lux and power of 0.29 milliwatts. And over 1 year period, twice a day, it just takes 3 minutes every time. So just 6 minutes of the child. Children did it quite willingly, maybe because it's China and it's not a democracy, but whatever. So 5 days a week this was done, and they measured the changes in the axial length and the spherical equivalent SER from baseline on each follow-up visit, and the children were followed up at months 1, 3, 6 and 12. This device was connected to the internet so that the people at the controllers, the scientists could follow whether the children were cooperating, were doing it or not properly. So they could observe this. Of course, now the machines are available without it being connected to the internet, so children can do it at home. But for the study, they were controlled and they were documented. And the more the compliance, which is there with every therapy, the study demonstrated, the more the control if the compliance was better. So some questions arise. Why 3 minutes twice a day? Perhaps instead of 3, what happens if we go to 5 minutes or 6 minutes? Perhaps instead of twice a day, what happens if we go 3 times a day? We don't really know, but no evidence was found to suggest that it would be unsafe. What are the results? So we are almost 264 children, and almost 250 of them qualified for data analysis. So the compliance was very high. There were no serious side effects. Median rate of treatment compliance was 75%. And look at this, which I've written in red, amazing results. That the axial length elongation was just 0.13 millimeters, and the spherical equivalent increase was just 0.2 diopters in a year, compared to axial length increase of 0.38, almost 3 times increase in those wearing only single vision spectacles, and almost 0.8 diopters of increase in number in the control groups. So 0.2 to 0.8, so almost 1/4 the increase with repeated red light therapy. So axial length amazingly was also seen to have shortened in about 40%, which we can't really explain. And the results were on renowned good instruments like IOL Master, which is acceptable. So what is the hypothesis? How does this treatment succeed? Recent evidence confirmed that sclera is the white outer coat of the eye, that hypoxia or less oxygen there is a promoter for scleral remodeling and myopia development. So if there is less oxygen to the sclera, the myopia increases. So they found, Jiang et al., that is red light therapy, because it's red, so it gives a little bit of heat, blood vessels expand, more blood flow increases to the sclera and the choroid, reducing the scleral hypoxia, restoration of scleral collagen, so you get better fibers at the sclera, the stronger fibers, so the sclera doesn't expand. So these are some of the hypotheses for this. And there were no differences in the anterior segment changes, such as anterior chamber depth or the corneal thickness and things like that. None of these changed. So there were no serious side effects. It's been approved by the Safety Council, which is equivalent to the FDA of USA. Only 2 patients discontinued, feeling the light was too strong. No other side effects. There are some limitations to the study. There's no masking done. Level of compliance was not assigned randomly. So they didn't know who will be more or less compliant. And it is not proven that if you use 627 wavelength, suppose you use 650 or 700, what will happen? If you use different the power intensities, exposures, all these things have to be checked by different other studies. But there was a study which tried to use a sham device, which gave only 10% of the original power. Both were well tolerated, but the myopia progressed with if you reduce the power by 10%. So we know that you can't reduce the power too much. Another thing was it was the duration was only 1 year. Maybe longer studies will tell us whether there are serious side effects over length of time or not. Some studies have now been carried out in Australia and in Spain as well. And we don't know what happens when you stop, whether there is any rebound effects, and whether this works in ethnic groups other than children of Chinese heritage. So early studies from Spain and Australia in Caucasians have also shown effects, but not as good as the Chinese ones. So in conclusion, the RLRL seems promising. We need multiple studies in non-Chinese children and longer duration studies and studies with different wavelengths and powers. I'm sure we'll get there in a few years. So to conclude, let us see what all we can do. Let's start with lifestyle changes. Give them minimum 2.5 hours of outdoor time if possible. Lifestyle modification. Reduce the junk foods, the pizzas and the burgers. Healthy foods, green leafy vegetables, colored vegetables and fruits. And regular timings for meals. And so these are some of the things which we neglect. So I put it right in the beginning in my concluding remarks. So the options to put the brake, we discussed orthokeratology or special lenses worn at night. We talked about low dose atropine, which is 0.01% or 0.05%, which can be used. Multifocal soft contact lenses were tried for a long time, but now given up as we have greater reliance on myopia control spectacles. So, as per the landmark Rose study of 2006, 20 years ago, spend minimum 2.5 hours outdoors in sunlight, avoid continuous close work, and pay some attention to their lifestyles, healthy food, and green vegetables. Thank you so much for your attention, and I'll be most happy to answer questions. Over to you, Saurabh.
So thank you so much. Thank you so much for such an insightful and wonderful topic. I think this is the need of an hour. I still remember all my nephews and nieces. They wake up in the morning, they go for Instagram reel. They sleep, they go for reels. And I think most of the reels are not even true, but it's so
Yes.
addictive that, people don't realize that what they are gaining and what they're losing. So now I will open the forum for the question answers. We have our chairman over here and we have our president as well here. Dr. Chong, please take over.
Thank you, Dr. Maskati. I'm from Singapore. So as you know, Singapore is a myopia capital of the world.
Absolutely.
By 7 years old, 25% of our children are myopic. By 12, 65%. By young adulthood, 83%.
Yes.
So this is, of course, very endearing to me, this topic, because I myself am a high myope. So this is really fascinating topic.
I've come several times to your wonderful country and lectured at the SNEC and at the Singapore General Hospital as well. So I've seen firsthand your myopes. Yes.
Yes, quite appalling our myope rate. So without much further ado, I'll open the questions to the floor. Anybody has any questions for Dr. Maskati?
Sir,
Dr. Maskati, yes.
So one question I have, these anti-glare glasses people usually wear for looking at the screens, like even as a corporate, like we forget about the people, like the
Yes.
phones
So
and
they are
everything. Even
more
for work,
commercial,
people are so
Saurabh. They are
dependent.
more for commercial reasons. In the US, the American Academy of Ophthalmology keeps issuing caveats saying, please don't go for all these blue light prevention spectacles and anti-glare. It's not, the whole idea is don't be continuously on a screen. When you're on the screen for more than 30 minutes, take a break for about a minute where you close your eyes or look far away, the 20-20 rule. And blink more often when you're on the screen. And avoid gadgets at night. See, the thing is, if you want to fall asleep, something which I didn't mention in my talk is the importance of a healthy 7 hours sleep for everybody. So if you are looking at your gadgets, your mobile phones, you're doing a Sudoku puzzle or you're looking at reels just before you go to sleep, it's not helping you to fall asleep. So there, if you have a blue light control, the melatonin is not blocked and you can sleep better. But instead of that, the better thing is for an hour before you sleep, simply switch off all gadgets. If you must watch something on TV. The larger the screen, the less the harmful effect. Thank you.
Distance also.
There's a question on the role of LASIK. That's probably after the fact, but
Yeah,
any
the
comments,
role of
Dr.
LASIK
Maskati?
is not for this whole talk was on prevention and control. LASIK,
Yeah.
as Dr. Chang quite rightly said, is after the fact. If you're above 18 and your number has not progressed for a year, your eye surgeon will determine if your eye is suitable for LASIK. And yes, I am a strong proponent of LASIK. I've done it for my daughter as well. So it's a great thing, but that's much later, after the age of 18. Till then, if I can prevent you from going
Yeah.
towards high myopia, so much the better. The other question on self-adjusting glasses. Now, these self-adjusting glasses are more in the underdeveloped areas where the optometrists can't reach or they can't afford glasses. So we have a liquid in the spectacle, and with knobs on the side, you can adjust those to see clearly. So if the number changes, you can adjust those knobs. More or less liquid goes into the. So these are inexpensive glasses which can last for long. But this is not for myopia control. This is just as a treatment. It's a single vision spectacle sort of thing. More in Africa and other countries that it's being given. And the question by Dr. Bharat Bhushan Agarwal, can you combine treatments? Yes, you can. My own granddaughter that I alluded to is on atropine, low dose atropine drops, and she's wearing the special glasses, the Stellest glasses. And just yesterday I saw her, and 1.5 years down the line, since she's been doing this, her number has not gone up at all. So her number went up when she was only on atropine. So I added these Stellest glasses. Again, no commercial or financial interest. It could be any of those. And when I gave this combination, I found that since the last 1.5 years, the number has not gone up. So yes, you can combine two modes of treatment. That is the beauty.
Excellent. Thank you. Any other questions from the floor? Well, Saurabh, are there any more questions?
No, I don't think there is any more questions. I think it's a very important topic, but we will like to invite you for another forum. But I think we would like to have some take-home messages from you for our youth and younger generation and
Yes,
people who
so
are
let me quickly summarize for those who came in a little late. Please spend more time outdoors. It is the sunlight which helps, not artificial light. So sunlight minimum 2 hours plus outdoors. Please spend as little time as possible on gadgets. Don't use gadgets for pleasure. Use it only for necessary schoolwork which has to be done. Do it, but don't use it for video games. Don't use it for reels. If you must use a gadget, the larger the gadget, the better it is. So TV is better than a laptop, which is better than an iPad, which is better than the phone. And sit appropriately as far away as possible. Don't bend your neck like this too much. Hold the gadget little at your eye level so that later on in life you don't have orthopedic problems. Eat well, sleep well, and have a large, good circle of friends to play with, and you will be halfway down even without the special glasses and the atropine which your doctors will give you. I think this take-home message of lifestyle can be given by everyone in this audience to their friends, relatives, patients, whatever. Thank you.
Thank you, Dr. Maskati, and it was a very good presentation. Enjoyed it tremendously, and I'm sure our audience did as well. Thank you very much, and we hope to see you again soon for another presentation. Thank you.
Thank you.
So thank you everyone for joining in. See you again for the next session. Thank you, Doctor, for the wonderful session.